Hello, everyone. This is Jingwei Liu from China. I'm the president of the Maple Prime Care Transformation Research Center. It's my great honor to have this opportunity to join this international conference. I will leverage this chance to share with you some of our experience in China by empowering nurses to managing chronic disease. As you know, China's health system and the structure is an inverted triangle. And we don't have a very strong the family physician or the GP system. And when people have disease, most of them directly go to the second level or the tertiary hospital. How to enhance the prime care is one of the key challenges of the China. About 8 years ago, we began to looking at the international experience, especially the patient-centered medical home of the US. We learn from that the international experience and try to adapt a new technology, information system, and to transform the China's existing primary care system to the team-based new delivery model. We began the journey about 80 years ago, and we introduced the key best practice of the PCMH of the US. One is we learned from the University of Utah. There's a team delivery model, and also the structure, the how to integrate the large hospital and with the primary care clinic is one of our reference. Another one we learn from is the best practice of the PCMH is the SETMA, the Southeast Texas Medical Associates. And from that, the best practice, we learn how they using the IT system to systematically manage the patient care, especially the chronic disease. And we learn from the experience of the veteran affair, how to roll out large scale the PCMH team-based care in the US. And we identify one million district of China in the southwest part of China in Sichuan province and Chengdu, the Wuhou district. We begin our journey by hosting the first the PCMH conference 80 years ago. We invited the Paul Grundy, the very famous godfather of the PCMH, to make the presentation and introduce the US experience about the team-based care. Since then, we began to explore the patient-centered new service model transformation and focused on how to do the integrate the nurse and the physician in a team delivery model and adopt the evidence-based care and to make the nurse to take more responsibility for the care coordination and provide the comprehensive care to the patient and engage patient more in their own the health. And to make this transformation, we found one of the key challenge is the physician don't have the enough time to provide the comprehensive and coordinated care. No matter for the comprehensive care, they need more to do the disease registering and increase the patient outreach and enhance the patient's communication and to spend more time to coordinate the care cross healthcare organization and between the patient and the care team. So all this the new work is a very time-consuming task. It's impossible to by the physician themselves to take over of this. So there comes the new role of the nurse in the team-based care. In China, a lot of the nurse plays a role in the public health system. And by adopting the medical home delivery model, we reposition the nurse role in the population health management. They take more role onto the management disease by register the patient in the disease system and to do the pre-visit chart review and to do the patient education and care coordination and facilitate the physician to do the group visit and also using the IT tools to support the quality improvement campaign. All of these things began to shift the workload from the physician to the nurse. And for the team-based care in the Wuhou district, we established the core team. The core team usually including the physician, the PCP, family physician, and the medical assistant and the registered nurse. They as the core to in charge of about the 1,000 population's health. And in the district level, there is a supporting team to support the population health management, including the specialist and the pharmacist, nutrition, and other key roles. And the principle for the team-based care, we adopt the top of the license. So, and we redesign the workflow and redesign the task. If one task can be done with the physician or the nurse, we will encourage to nurse to take this responsibility. And the job redesign and the task reassign is continue. And usually every quarter we will continue refine the work assigned to continue improve the responsibility and skill of the nurse. To make this transformation, and we focused on the chronic disease population and empower the nurse to join the team-based care to manage the chronic disease population. How we empower them is first we enable them with the IT tools. This IT tools we call the electronic patient management. We integrate the patient data in one repository and with the decision support and rule engine to identify for each patient which is the care gap, how to improve their care, and with a different color to remind the nurse to focus on the specific areas. For the population, we will help the nurse to identify the whole population's healthcare care gap and prioritize the focus, then define the related the health intervention campaign to engage the population's health. And the second approach is we will work with them, help them to continue re-engineering, improve the workflow to improve the cooperation with the physician. And a third approach, we will empower them with the new technology, the AI-enabled medical device. For example, we found for the diabetes population, a lot of them, very high percentage of them, don't do the eye examination. We provide the AI-enabled the eye examination, the machine. And this machine will help the nurse to automatically screening the population and triage the high-risk patient. Then they will do the follow-up and the care coordination for the high-risk population. To make this transformation, it's not only the top-down mandate approach, but we adopt the transformation learning collaborative methodology for the new type of the training. The training is not only just the shared knowledge, but how to reorganize them to let the peers share their experience and help them to, based on the data, to define the short-term goal and to measure their progress and help them analyze the outcome and have the one small cycle, another small cycle, follow another small cycle to do the step-by-step improvement. For the For the improvement measurement, we adopt the international standard of the quality metrics, especially for the diabetes and hypertensions, for the A1C, for the food examination, flu shot, all this, the KPI of the quality, we adopt the US standard, the NCQA standard. And we're using the IT system to integrate the data from the workflow and automatically have the reporting system to present the performance to the each team, each clinic. So if you look at this slide, that is for each team we will have feedback them with how many people they are managing about the diabetes population, hypertension, how well they manage the population. From the KPI of the A1C, of the LDL and BP, and have the scorecard to each team, to each the clinic in the real time. So usually each team every week will, based on this data, to identify how to improve their chronic disease management. And the methodology is to have the near real-time quality tracking and weekly analyze to analyze the report. And we will also publish the report to have the peer pressure and also to let them compete with each other to improve the scorecard. So this and on the other way, we will based on the quality metrics to identify the work to be done, and then automate the population health management task to improve their efficiency. And most of the population engagement work is done by nurse, but the quality metrics and the quality improvement program is designed by the physician. So in the past more than 4 years, we found the very encouraging outcome. This slide, if you look at that, this is the last year's scorecard for each clinic. And we also can break it down to each team. And you look at that in the 2017, and when we begin this transformation about 1 year, just 1 year, the average score about the diabetes management is only 30. Right now, last year, their score risen to 65. And we also found the diabetes population being managed almost double. About 4 years ago, the whole team, the team only managed about 13,000 diabetes. But right now, the same group almost manages 25,000, almost double the number, the patient number, and also the double the scorecard. So this is a long journey. And 80 years ago, we began to introduce the team dynamo model by introducing the PCMH to China. And 7 years ago, we began the first pilot in the Wuhou, in the urban area, and to localize the US PCMH model for the China's environment, the policy environment and workforce environment. Then about 4 years ago, 3 or 4 years ago, we tested this model in the rural area. It's the Hejiang County. We also found a very encouraging outcome. And 1 year ago, we began to introduce this model in the integrated care, including the district levels of hospital, integrated with the primary care. The pilot in the US called the accountable care organization. In China, we call it the integrated care system. And right now, no matter from the provincial and municipal government, begin to pay attention to our good progress and supporting our exploration. And we will find a lot of the other district, other county come to visit our pilot, would like to introduce this model to their own practice. We found this model have the high chance in the future to begin to roll out. After the 80 years journey, we found In the team deliver model, especially in the primary care, nurse could take more and more important responsibility and create more value for the whole the population health management. I think our exploration, we will continue move on. We are also looking forward in the future to learn from you, to adopt your best practice, how you empower the nurse in the future to adopt your practice experience in China. Thank you.